Welcome to the Deep Dive. Today we're tackling a really important question in treating abdominal aortic aneurysms, AAAs.
Those potentially dangerous bulges in the aorta, yeah.
Exactly. We're zeroing in on how two different surgical approaches, the traditional open repair and the less invasive endovascular method, how they stack up. Not just right after surgery, but years later.
hmm And our main source here is the long-term follow-up from the DREAM trial. That's the Dutch randomized endovascular aneurysm management trial.
Right, a really significant study. It's even in that book, 50 landmark papers every vascular and endovascular surgeon should know.
It is. So the core question really is this. Does that initial benefit we often see with endovascular repair actually hold up long-term?
You mean considering things like survival and needing more procedures later on?
Precisely. We're talking data up to 15 years out. We'll be digging into the trial results and also some expert analysis on what it all means.
Okay, let's unpack this. Why should you, the listener, care? Well, if you or someone you know is dealing with in AAA, understanding these long-term trade-offs is absolutely crucial.
It really is. It's about making the most informed choice, thinking about the years ahead, not just the immediate recovery.
So true.
Okay, so to get a grip on the long-term stuff, we kind of need to start with the original DREAM trial, right? What was its main aim?
Yeah, good point. The original trial was set up to directly compare open surgery versus endovascular repair for
A
AAAs.
head-to-head comparison.
Exactly. It was a big deal, multi-center, randomized. They wanted to see which approach gave better outcomes initially.
And who were the patients in that original study? What were the inclusion criteria?
They focused on patients with asymptomatic AAAs, so no symptoms that were at least 5 centimeters wide.
Okay.
And importantly, these patients had to be suitable for either open or endovascular repair.
So they could potentially receive either treatment?
Right. Plus, they needed the right anatomy, a life expectancy of at least 2 years, and be okay for abdominal surgery if needed.
Makes sense. And I assume there were also clear reasons someone wouldn't be included, exclusion criteria.
Oh, definitely. The list was pretty detailed. Things like already having a ruptured or symptomatic AAA.
Because that's an emergency, requires immediate action.
Exactly. Also, aneurysms smaller than 5 centimeters, or ones too close to the kidney arteries.
Okay.
Inflammatory AAAs were out, anatomy not suited for endovascular repair, needing to block off both hypogastric arteries. Also, certain anatomical variations, people unsuitable for open surgery, contrast dye allergies,
Wow, quite specific.
active infections, transplant patients, limited life expectancy less than 2 years, bleeding disorders, and certain connective tissue diseases too, so a very defined group.
Right. So with all that, how many patients actually ended up in the randomization?
Initially, 351 were randomized, 178 to open, 173 to endovascular.
Okay.
But after a few exclusions and some crossovers or conversions, meaning they got the other treatment, the final numbers who actually had the repair were 173 open, 171 endovascular.
Got it. And how long did that original trial follow them?
The main follow-up for the original DREAM study was 2 years.
2 years. Okay. Enough to see the early results and complications.
Right. Which sets the stage nicely for the long-term follow-up study, which is really our focus today. What was the goal there?
So the main aim of this longer look was to see what happened regarding survival and, critically, whether patients needed more procedures.
And this was looking out much further.
Yeah, way further, up to a potential 15 years. They wanted to know if those early patterns held true over a much longer time.
15 years is a long time in medicine. How did they even gather that data so long after?
Well, it was retrospective. They went back through medical records, death records,
Right.
and they also contacted the original doctors, patients, sometimes even relatives, to piece together the health history since the trial ended.
Right, so digging back through the archives, essentially. And what was the typical follow-up time they managed to get?
The median total follow-up was pretty impressive, 10.2 years.
Wow.
Yeah, and the middle range, the interquartile range, was between 5 and about 12 and a half years. So really substantial long-term data.
Okay, so after all that time, what was the big finding on survival? How long did patients in each group live?
This is where it gets really interesting. After 12 years, the overall survival rates were actually very similar.
Similar. Between open and endovascular.
Yeah, 42.2% for the open repair group and 38.5% for the endovascular group.
A small difference numerically, but
But statistically, not significant. The p-value was 0.48, so basically that difference could easily be down to chance.
so over 12 years, no real difference in overall survival based on which surgery they had first.
That's what this data suggests, yes.
What about deaths specifically related to the aneurysm itself? Any difference there?
Also, no statistically significant difference found there either. At 12 years, it was 7.7% aneurysm-related mortality in the open group and 3.1% in the endovascular group.
Lower in the endo group, but again, not statistically significant. P.33, right?
Correct. P was 0.33. So
Right.
again, couldn't rule out chance as the explanation for that difference.
Okay, those survival findings are, well, quite something. Let's switch gears to reinterventions then, because the thought was maybe more procedures after EVAR could impact survival eventually. What did they find?
Now this is where a very clear, significant difference showed up.
Okay.
The rate of freedom from needing a secondary procedure was much higher in the open repair group.
Meaning fewer patients needed follow-up surgery.
Exactly. At 12 years, almost 79% of 78.9% of open surgery patients hadn't needed another procedure,
Compared to...
compared to only 62.2% in the endovascular group.
Wow, okay, that's quite a gap. 79% versus 62%.
It is a statistically significant difference, p equals 0.01.
Can you sort of quantify that difference in terms of how often these procedures happened?
Sure. If you look at the rate, it was much lower in the open group. 2.8 events per 100 person years.
Okay, person years being number of people times years followed.
Right. Compared to 6.6 events per 100 person years in the endovascular group.
More than double the rate.
Significantly more, yes. P, less than 0.0001. Highly significant.
And what was driving that higher rate? What were these extra procedures for in the endovascular group?
The main reason was interventions for what's called incomplete aneurysm exclusion.
Meaning the graft wasn't fully sealing the aneurysm, like endoleaks.
Precisely. Problems with the endograft itself, or issues like endoleaks that needed more treatment to make sure the aneurysm was properly dealt with, that was significantly more common after endovascular repair.
Okay, so definitely more reinterventions after endovascular.
Yeah.
But despite that, did they look at survival without needing those extra procedures? Reintervention-free survival.
They did. And interestingly, even with more procedures in the endo group, there was actually no significant difference in that combined outcome living without needing another intervention.
Really, what were the numbers there?
At 12 years, it was 34.9% for open repair versus 26.5% for endovascular repair.
So again, numerically different, but statistically.
Statistically, P was 0.13, not considered significant, could still be chance.
Okay. And one last technical point. How complete was this long-term data? Did they lose track of many patients?
No, the follow-up was remarkably complete, 98.4%.
That's incredibly high for such a long-term study.
It really is. Gives us a lot of confidence that the findings are pretty reliable, not skewed by lots of missing data.
Okay, so that's the detailed picture from DREAM. Now let's bring in the expert commentary. How did the experts interpret these findings? What are the implications and maybe the limitations?
Right. The commentary is key for context. One point experts highlighted was that initial hypothesis that maybe the higher reintervention rate with EVAR would eventually hurt survival.
Which didn't quite pan out in the survival data itself.
Exactly. Survival was similar, but the study certainly confirmed that higher need for secondary procedures after endovascular repair. No question there.
And what about limitations? Every study has them. What did the experts point out for this long-term follow-up?
Several important ones. One big thing is how type 2 endoleaks, those specific kinds of leaks, are managed. Management has evolved quite a bit since the DREAM trial started, back around 2000.
How so?
Well, back then, the tendency might have been to intervene on those leaks more readily. Today, there might be more of a watch-and-wait approach for some. So the high reintervention rate seen in DREAM's endo group might be partly due to earlier practice patterns.
Okay, so maybe fewer reinterventions for that specific issue today.
Potentially, yeah. It's a factor to consider.
What other limitations were raised?
Another really key one is the devices themselves. The endografts used back in the original trial were older generation technology.
Right, things have improved since then.
Significantly. So the reintervention rates seen with those older devices might not fully reflect what happens with the newer, more advanced endografts used today. That limits generalizability.
Makes sense. Anything else?
And of course, the fact that the long-term data was collected retrospectively. Looking back always carries potential for inaccuracies or recall bias from patients or families.
Right. And you mentioned something about how closely patients were watched afterwards.
Yes, exactly. The commentary noted that patients in the endovascular group generally had more frequent surveillance imaging after the main trial ended compared to the open group.
So you might find more problems just because you're looking more often.
That's the concern. It's called ascertainment bias. It could inflate the number of detected complications or needed re-interventions in the endovascular group simply due to more intensive follow-up.
Okay, those are important caveats. Did the experts connect these dream findings to other big trials?
They did.
Hmm.
And the findings are actually quite consistent with other major studies, like the EVAR-1 trial.
What had that show?
EVAR-1 also found higher reintervention rates in the endovascular group at 15 years, and it even suggested higher aneurysm-related mortality after year 8, mostly from secondary ruptures after EVAR.
Hmm. Any others?
There's the OVER study. It didn't find a difference in overall death rates after 3 years, but it did report more aneurysm ruptures later on at 9 years in the endovascular group.
Okay.
And even a large analysis using U.S. Medicare data pointed towards a higher rate of aneurysm rupture after 8 years in patients who had endovascular repair.
So a pretty consistent pattern across different studies and populations regarding long-term issues, particularly re-interventions and maybe even late ruptures after EVAR.
It does seem that way, yes.
So what's the main takeaway message from all this then regarding endovascular repair?
I think the big message is that while EVAR is less invasive upfront, it isn't necessarily a one-and-done fix in the way open repair might be. Meaning patients often need lifelong surveillance, lifelong follow-up, and they do face a higher chance of needing more procedures down the line compared to open repair.
How does that change the conversation between doctors and patients deciding on treatment?
Well, the expert commentary really hammers home the need for extremely thorough informed consent.
Making sure patients really understand what they're signing up for.
Exactly. Patients considering EVAR need to know about the ongoing monitoring, the imaging scans, the potential for future interventions. It's a long-term commitment.
I heard some doctors even use a specific agreement for this.
Yeah, some physicians actually use a signed contract or agreement to formally document that the patient understands and accepts the need for this lifelong follow-up.
Wow. Finally, the experts raised an interesting point about who is the right patient for each approach, especially considering this long-term data.
Yes. Based on these findings, you have to ask, is EVAR always the best choice, especially for younger, healthier patients? People with a long life expectancy who could tolerate open surgery well.
Because open surgery has the tougher recovery up front.
Right. A bigger initial hit
Right.
surgically, but it seems to come with fewer late reinterventions and less need for that intensive long-term surveillance.
Versus EVAR being easier initially, but carrying that long tail of potential issues and follow-up.
Precisely. It's a trade-off. And that trade-off needs to be discussed really carefully with each individual patient, considering their health, their age, their lifestyle, their preferences.
Okay, so let's try and summarize the main points for our listeners from this deep dive into the DREAM trial's long view.
Sure. I think the key things are: 1, endovascular repair offers that initial advantage, less invasive start. 2, long-term survival out past a decade looks pretty similar between EVAR and open repair based on this trial. But 3, there's a significantly higher need for more procedures, these secondary interventions, after endovascular repair compared to open. That's a consistent finding.
And why is grasping these long-term implications so vital?
Because it's crucial for informed decision-making, for
Yeah.
patients and clinicians. It's not just about the surgery itself, but about the patient's health trajectory, potential future burdens, quality of life for many years afterwards.
It really does give a lot to think about.
Absolutely. So here's a final thought for you, the listener. Given these long-term findings, how do we balance that initial appeal of minimally invasive approaches like EVAR against this potential for more interventions later and the absolute need for strict lifelong monitoring?
Yeah, what does this tell us about how we adopt new medical technologies? And just how critical it is to keep following patients for years, even decades, to truly understand the full impact.
It's definitely something worth mulling over.